Yeah. Okay. Good morning, everyone. Sorry for any technical difficulties I'm having. Hopefully we'll be all right. If you don't see me, it's to preserve function. Anyway, I'm really happy that we have Dr. Robert Owens back with us. I think it's been a 2 or 3 years since he last presented. So for many, this will serve as an update and probably for most new information. So Dr. Owens is a professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine and the Sleep Medicine Section Chief at the VA in San Diego. Cares for patients in the ICU and in the sleep medicine clinic. His research is focused on the pathogenesis and management of obstructive sleep apnea, the most common respiratory disorder in the world, which is cardiovascular, metabolic, cognitive, and quality of life consequences. He and Dr. Igor Grant were multiple PIs on a recent National Heart Lung Blood Institute, I guess that's the NHLBI,
Mhm.
RO1 to study obstructive sleep apnea in people living with HIV. And we're really excited to hear about what I hope are the results or wherever we are with things.
Great. Thank you, Jill. I really appreciate the invitation. And I think you're right. I think, the main point of my talk today is that sleep apnea is incredibly common, and I think it's incredibly important for your patients. And yes, we're going to go over some of the results from our RO1. And by way of disclosures, even from that introduction, it just reminded me I feel even more like the fifth Beatle here. So, I really am a critical care and sleep medicine physician. I have limited to no HIV knowledge. And as you mentioned, Igor Grant and I were fortunate enough to have a RO1 funded by the Heart, Lung, and Blood Institute. And so, really coming to tell the story of that grant, and people like Miley and others were very instrumental in the success of that grant. And so see what we've learned. And then, time has lost all meaning, at least to me, after COVID. And I actually last presented here. I can't quite figure it out, but it was like the last week of February or possibly the first week in March. And it was like right before the entire world shut down. So my disclosure is if that happens again, it's probably me, but hopefully not. So anyway, by sort of the outline for today, I'm going to spend just 10 minutes, again, kind of talking about obstructive sleep apnea, what it is. I have to spend a little bit of time talking about how we assess the severity of sleep apnea, some of the tools that we use, just to give you some background. I'll just spend about 5 minutes on what was known about obstructive sleep apnea in people living with HIV as of about 2016, which is when we wrote our grant, and sort of before we started collecting data. And then what's really interesting, so I'll talk about our results from the RO1, but the NHLBI had a call for proposals, and there's actually a couple different groups that have been doing work on HIV and sleep apnea. And so all of the data that I'm going to present in the bulk of my talk really comes from the last 2 years or so. And it's about prevalence of sleep apnea, how we should screen for sleep apnea in patients living with HIV. Does it matter that they have sleep apnea? And what happens if you treat somebody's sleep apnea? Do they feel better? What kinds of things get better? So I this will actually be, I think, pretty timely. Okay, so this is sort of a very brief overview of obstructive sleep apnea, just to make sure we're on the same page. But obstructive sleep apnea is repetitive collapse of the upper airway during sleep, and that leads to hypoxemia or low oxygen, and then arousals from sleep. And these can be micro arousals. But both of these things, the low oxygen, the activation of your fight or flight response system, has been linked causally to cardiovascular diseases like hypertension. And then people don't feel good. They have daytime symptoms such as tiredness or not thinking clearly. And this is something I probably showed at this forum over the years, but this is what sleep apnea looks like to me. So I'm showing you a screenshot of 60 seconds from a polysomnography, so an overnight sleep study. And I think you can see the laser pointer here, but I want you to just look at the airflow measures here. And this is a patient breathing in and out. And then you can see there's a long pause where nothing happens for about 40 seconds. And that's despite the patient still moving their chest and their abdomen. So they're trying to breathe, but no air is going in, and that's because their upper airway is collapsed. And in that setting, the oxygen saturation goes from 94% all the way down to 65%. So we have oxygen desaturation, and at some point, uh, part of the brain says, "Hey guys, we got to wake up. We need air." And so there is activation of the upper airway muscles. There's some brainwave activity, which is subtle if you're not used to looking at these, and people start to breathe again. If you're really interested in sort of the mysteries of sleep, these are the eyes that we measure the movements of the eyes at night. And these equal and opposite deflections in the right and the left eye. And you sort of have to look at my hands, but these are the eyes kind of flicking left and right. And that's what rapid eye movements are. So this is rapid eye movement sleep, and it's a particularly vulnerable time in terms of sleep apnea. So these apneas can happen many, many times. So now zooming out to a 3-minute window, and you can see patient has no airflow. They take 3 or 4 big breaths. This is, commonly people report, big snort awake. They go right back to sleep, and the same thing happens. And you can see the oxygen going up and down as you have these repetitive oxygen desaturations. So this is where things will, it seems pretty straightforward. We count up the number of these apneas and hypopneas, and we divide by the total sleep time, and we get something called the apnea hypopnea index. And that's, I don't know, you tell me, that would be our viral load or CD4 count. That's kind of our bread and butter. And that's how we assess severity. But, where things get complicated is that we have apneas, which are pretty straightforward, but we also have these things called hypopneas. And a hypopnea is a reduction in airflow that has a consequence. So either the oxygen goes down or somebody wakes up from sleep. And so just as an example in this figure on the right of the screen, here's an apnea. So no airflow, and you can see kind of a big corresponding oxygen desaturation. But you can also have reductions in airflow. So there's still air going in and out here, and there's not quite as much of an oxygen desaturation. But at some point, this person has an arousal and they wake up from sleep and they start breathing again. And in our field, sort of the embarrassing part, like this makes it hard for me to come and talk to all of you, is that different people define a hypopnea differently. And you can say, well, I want reductions in airflow that lead to a 3% oxygen desaturation, which is not a high bar. That's kind of easy to do. Other people, like Medicare, say, no, you have to desaturate 4% before we will consider that you have sleep apnea and pay for your CPAP machine. So what I'm trying to say is that these different definitions of hypopnea lead to different measures of prevalence. It affects how many people we label as having sleep apnea, and it affects the severity. So again, like when I talk to colleagues in the field, we're like, man, I can't believe we can't agree on this one definition. And so you'll see as I go through, it kind of, you'll see some numbers, and I try to shield you from some of that. The only thing that I will say that sort of mitigates this a little bit is that, this 4% oxygen desaturation criteria, that corresponds actually pretty well or better than other metrics with cardiovascular consequences of sleep apnea. And yet the arousal-based definitions, that corresponds better with sort of cognitive performance during the day. And so, sleep is so, it affects so many things. It's unlikely that one metric is going to sort of capture everything. So the analogy I use is that AHI is like saying there is arrhythmia, like a heartbeat. Yes, there's something that's going on, but it doesn't tell you if that arrhythmia is kind of benign or more severe. And that's some of the stuff that we do, is try to sort this out. So I spent a lot of time on that because you'll see these different definitions as they come into play. But just to go back a little bit about how common sleep apnea is. So this is a paper from the New England Journal in 1993. So it's 30 years old. And this is a true prevalence study. They went out into the community. They happened to find, this is Wisconsin, so I don't know if there's anybody there, but they looked at Wisconsin state workers and they signed them up randomly for sleep studies. And about 20% of the male population had an apnea hypopnea index greater than 5, and about 10% of women. And then if you focused on people who complained of sleepiness, it was about 4% of men and 2% of women. And the reason this study got in the New England Journal of Medicine is that this prevalence was on par with asthma, which was generally considered the most common respiratory disorder at the time. So this sort of said, hey, sleep apnea, should be on the map. And speaking of maps, I know you've all seen these heat maps, but we have grown as a country in one specific way, I guess, over the last 30 years. And so this is the obesity measures across the country. And because weight is the greatest risk factor, particularly in Caucasian populations for sleep apnea, no one's done a true prevalence study, but it's estimated that about 1 in 5 middle-aged men has moderate to severe sleep apnea, and 1 in 10 middle-aged women have moderate to severe sleep apnea. Women are protected from sleep apnea until menopause, and then they catch up. So that's something of sort of the epidemiology. In terms of consequences. I won't go into this in great detail, but again, the sort of neurocognitive consequences, people feel tired. And unfortunately, that can have more severe consequences than just sort of a subjective feeling. There's increases in motor vehicle crashes, poor performance at work, that kind of stuff. And then on the cardiovascular side, things like hypertension, atrial fibrillation, heart attack, and stroke are some of the consequences. So, I will I have obviously more to go, but that's kind of the 10 minutes or less of sleep apnea that I wanted to cover. Um, Jill, you tell me, but if there are specific questions, I'm happy to answer them about sleep apnea in general, or we can wait till the end. But
I was
that's
gonna
just the
let you, yeah, I was gonna let you go. People ask questions, and then I'll give you like a 15-minute warning. I know people will want to ask questions, so
perfect. Okay,
yeah.
so that sounds great. Thank you so much. And I appreciate those of you who are not off in Zoom land and I can see your face. But anyway, so there were some hints that sleep apnea might be important in people living with HIV. So, I had the opportunity to meet with Chuck Hicks years ago when he was the medical director of the Owen Clinic. I will say that in our research studies, I feel like the participants were very confused that my last name was Owens and that they were coming from the Owen Clinic and they thought I had like some special in, but I'm here to tell you there's no relation. And, talking with Chuck, what I learned, and I blame him if I'm wrong on this, that was that people with HIV who were on antiretroviral therapy, were doing very, very well in many ways. Um, but there were major comorbidities or symptoms of things like fatigue and cardiovascular disease that remained a little bit unexplained at the time. And, when you're a hammer, everything's a nail. So I was like, people are tired or have fatigue and they have cardiovascular disease because they have sleep apnea. So Chuck and I wrote this Viewpoints article in CID, published now back in May 2018. And what's interesting is if you think about the comorbidities in this left column and what you see in people living with HIV, and I won't go into this in any great detail, but people living with HIV have diabetes, increased cardiovascular risk, cognition problems, and all of the same things can happen with sleep apnea. And there's another column to this figure here, which was, has this been studied in people living with HIV and OSA? And it was like, no. So a lot of work to be done here. And even though we thought sleep apnea was going to be important for people living with HIV, or at least would be common, the data at the time suggested that OSA was really infrequently diagnosed in people living with HIV. So this is a study that reported the comorbidities from a large sort of, a kind of a similar group to the Owen Clinic, although it's not from the Owen Clinic, but, in that cohort of all the sort of diagnosed comorbidities, you can see that obstructive sleep apnea was dead last at 4%. And yet, even back at the time that this was published, there was some evidence that sleep apnea was likely much more common than that. And so, for example, if you looked in a VA cohort, a veterans cohort of HIV patients, the prevalence of OSA was 15%. And you may know if you work at the VA that if you're diagnosed with sleep apnea, you get more benefits. And so there's a reason to be diagnosed more frequently. So, there's a higher number there. There was a study that had asked people, hey, has anyone ever said that you stop breathing, which is a pretty specific marker of sleep apnea? And a quarter of the people in that cohort said, yes, somebody has said that to me. And finally, there was one cohort study, again, cohort study, not a true prevalence, but in the MAX cohort, They had run some sleep studies there and found that about 75% of their subjects had sleep apnea. And that's despite the fact that in that cohort, the average age was 49 years, which, since that's how old I am, gets increasingly younger every year and robust. And the BMI on average was 25, and only 12% of the participants were obese. So, it seemed to me that OSA was grossly underdiagnosed in this cohort, or sorry, in people living with HIV. And this is the best I can do with PowerPoint sort of animations here. But sleep apnea affects all these other things on this slide, so it seems like it would be very important to diagnose sleep apnea. So back in 2016, it was kind of thought that I'll say that this is what was not known about OSA, but this is what was suspected about sleep apnea in people living with HIV, that it might be common, that traditional risk factors like age and weight may not predict sleep apnea as well, that OSA might be important for symptoms. Again, that study where they asked about witnessed apnea, that was the biggest risk factor for fatigue, more than current opioid use, more than antidepressant use, more than sleep duration. There were some small studies that had suggested that untreated moderate and severe sleep apnea was associated with higher viral load and inflammation. And again, very few people were treated. So in that setting, and this is a slide I just was looking at, last night as I was putting this together. In that setting, the NHLBI, the Heart, Lung, and Blood Institute, put out this call for proposals back in 2018. And what they wanted to see is sleep health and circadian biology and HIV-related comorbidities. So I put this mostly to go into timeline, but this was something we submitted in 2018. And then in early 2019, this grant was funded. So the title of the grant we put in was Obstructive Sleep Apnea Endotypes and Impact on Phenotypes of People Living with HIV. I would think of endotypes as, subtypes or, sort of different kinds of sleep apnea. I'll get into that a little bit. And then what are the different symptoms of people living with HIV? And Chuck had left for, I think it's ViiV Healthcare. And so Igor Grant became the MPI, and which was a great match. And Miley was probably the most important co-investigator on this grant with us. So it was a great team. And we had a couple questions, which I'll go over today. But the first question was, and our aim one was, does untreated sleep apnea contribute to fatigue and cardiovascular risk in people living with HIV? And does treatment of OSA with CPAP improve these symptoms? Now, there's a little bit more about kind of my science about the subtype of OSA, and I'll allude to that a little bit, but I'll really be focused on these clinical questions about, if you're seeing a patient in your clinic, should you think about sleep apnea? And so that's what I'm going to spend, probably the next 25 minutes or so, is going through the data from our study about prevalence, how to screen, that kind of stuff. And because the NHLBI funded a couple different studies, there's work led by Naresh Punjabi, who's a friend and a colleague. He was at Johns Hopkins, did that early work with the MAX cohort there, and now is at the University of Miami. And so I'm pretty much going to show you data, published data from our group or their group. And almost all of it, I think, is, as I said, in the last 2 years. So first question is OSA common in those with HIV, and are people with HIV more likely to have sleep apnea? So the closest we have is this study by Dr. Punjabi's group, and this was published in one of our sort of pulmonary journals 2 years ago, on the prevalence and predictors of sleep disordered breathing in men in the multicenter AIDS cohort study. And you probably know that MAX is a longitudinal cohort study of men who have sex with men with and without HIV. And subjects in that cohort, in that existing and ongoing cohort, were invited to do a home sleep test. So the reason I say this isn't a true prevalence study is that I can see people who suspected they have a sleep problem, or, yeah, I snore or whatever, kind of raising their hand and saying, yeah, I'll do this study and see what we find. In this study, people did home unattended polysomnography. So that screenshot I showed you of a polysomnogram, people wore at home EEG. And so we actually are able to look at all of the different definitions, including arousals from sleep, to see what the prevalence of sleep apnea is in this group. So their cohort was basically overweight, middle-aged men. So you can see they had pretty good sized numbers, about 450 men with HIV, 400 without, uh, men in their 50s. And sorry, I keep saying it, but this is all men. And the amount of data we have in women is very small. We have some of that data. And then these were generally on the cusp between sort of, normal to overweight based on BMI, mostly white and then black, but not a lot of Hispanic in this cohort. So what they found is that OSA is very prevalent, although it depends on the definition. So unfortunately, there are 4 different definitions on this screen. I will just walk you through the 2 most common definitions that we use. So you can see the column with those with HIV versus those without. And this 4% oxygen desaturation index, this is a metric that Medicare uses to reimburse CPAP and to diagnose sleep apnea. And by this definition, which is actually sometimes a little bit conservative, you can see that more than 50% of men with HIV had obstructive sleep apnea. If you really focus this down to a definition that focuses more on symptoms, and we use the American Academy of Sleep Medicine definition. So it's 3% desaturation, which is easier to hit in some ways, but you say, okay, only people that we really think have symptoms from sleep apnea, which we can talk about, but we're not always great about that. Then at least 15% of men with HIV had obstructive sleep apnea. And you can see that this column, whatever definition you use, it looks like those with HIV are more likely to have sleep apnea than those without, which was pretty interesting. And the reason that I say that it's interesting is my science is really trying to figure out why different people have obstructive sleep apnea. And so, we had sort of thought about this question, how could HIV be a risk factor for sleep apnea? So this is the life cycle of those apneas that I showed you on the, when we started, but you have to have a compromised upper airway anatomy, which is totally fine when you're awake because you have muscles that keep everything open. But when you go to sleep, you lose these muscles. Everything gets really quiet. The airway collapses. People start to breathe, increasingly hard. And at some point, that wakes them up, and they have this life-saving arousal, which unfortunately also leads to cardiovascular and neurocognitive consequences. But when we measure the airway anatomy, how active the muscles are at night, the control of breathing, or arousal from sleep, we find great differences between individuals. And I just highlighted this just as one example. Kind of what we find is that there are some people that really have an upper airway problem, and that's what we might traditionally think of somebody who is very obese. But there are other people that have really more of a sleep problem, and how you would treat those people, how you would think about them is very different. So when we think about how HIV might affect sleep apnea, I'm just throwing out ideas, but could it be in an older era that lipodystrophy causes something about the upper airway anatomy? Could it be that there's a myopathy or a neuropathy that affects the upper airway muscle? Are there things that affect sleep about HIV? And I'm going to just say that we have techniques to measure these sleep apnea traits. And I won't go into this more than sort of a 20-second overview of we bring people into our sleep lab. We put them on CPAP at a certain level to just kind of hold their airway open. And we just slowly or quickly lower the amount of support that we're giving them. And we see what happens. We see how they can recruit their muscles. We see what causes them to wake up, all these kinds of things. And I'm telling the story a little bit out of chronological order, but we had done a 2-year grant, this mechanism, which was really great, called Creative and Novel Ideas in HIV Research, the CNEAR program. So you had CFAR and CNEAR. And this was a program designed to bring in people that are, outside the HIV world into HIV, bring their research. And we had proposed this idea back in 2016 that we could look and see if those with sleep apnea and HIV look different than those without HIV. So this was work led by Jeremy Orr, and you can see that this is the pathogenesis of obstructive sleep apnea in people living with HIV. And we tried to find a way that HIV might predispose to sleep apnea, and we couldn't do it. All these traits that I just mentioned, the upper airway anatomy, how easy or hard people were to wake up from sleep, everything pretty much looked the same in these two groups. Now, I admit this was like 20 patients in each group, but we couldn't find any systematic differences in those with HIV and sleep apnea. And similarly, we investigated this. We actually did MRIs of the upper airway in the same cohort. And this is work led by Chantal Darken in our section of physiology. And, we brought people into the MRI scanner. Obviously, they look upright, but I assure you they were laying flat. We actually had people sleeping in the MRI scanner, which is, technically difficult to do. And the upper airways looked exactly the same. So this idea that HIV might be a risk factor for sleep apnea is something that is a little bit of a mystery to me. And I think the mystery has been solved just again in the last couple of years, because to me, everything up here in the upper airway and the neck and the brain is the same. But what's increasingly being recognized that HIV is a lung disease, and the most common abnormality of the pulmonary function test is a decreased DLCO. So this is the diffusing capacity for oxygen or other gases. And I think because our diagnosis of sleep apnea depends on oxygen desaturations, when you have a lung problem, you find more of these desaturations. So I think this has been, over the last, 10 years, we've thought about how HIV could be a risk factor. And all these really cool studies that are very labor intensive to look at the upper airway in the brain, like all that's the same, and it turns out to be a lung problem. So shame on me as a recovering pulmonologist for missing that, I guess. But anyway, so is OSA common in those with HIV? I would say absolutely. I think it depends a little bit on which definition you use, but many of your patients will have sleep apnea. And then are people with HIV more likely to have sleep apnea? I think based on our senior research, I think it's probably more of a lung problem than an upper airway problem. But yes, there's a little bit of a bump probably because of that. So if that's the case that many of your patients, coming to see you have sleep apnea, how should we screen for sleep apnea? And so let me just go over our sleep, or sorry, our R01 for a second. And, Miley, I recognize that we did not come up with a cool name for our study, so I feel bad about that. But what we were looking for were people who were aged 18 to 65 years old. We were looking for people who had a body mass index less than 35. And the reason for that is that if you have somebody who's much heavier than that, then it's all of an anatomy problem. And we wanted sort of a mixture of OSA subtypes. They had to be on antiretroviral therapy. The viremia had to be suppressed. And as they came into the study, they completed questionnaires. We measured cardiovascular health using something called peripheral arterial tonometry, which I'll talk about. Subjects wore actigraphy for a week, which I'll go over. Then they came in and did an overnight sleep study in our lab, and we got a blood sample the next morning. If they had obstructive sleep apnea, we offered treatment with CPAP, and our goal was 120 subjects, which I'm sure you all recognize, COVID-19 here. We did. We actually were able to enroll. We completed the study. I would just say it probably took us a little bit longer to analyze the results because of COVID. So how should we screen for sleep apnea? And if you don't know, there's a variety of questionnaires that are currently used for screening for sleep apnea. So things like the stop bang, there's something called the Berlin questionnaire. We frequently use in our clinic something called the Epworth Sleepiness Scale. And stop bang, for example, is something that is designed to be used in preoperative clinics so that an anesthesiologist is not surprised when somebody doesn't breathe well in the PACU. And this is what it is. It's 4 questions that you ask the patient. Do you snore? Do you get tired? Anyone ever say you stop breathing? Do you have high blood pressure? And then you can fill out most of these other things from the medical record. And if people score above a certain, number of points, basically, it has a pretty good sensitivity and specificity. So we looked in our cohort to see if these tools would be good tools for screening. And this was work led by Chris Schmickel, who's faculty in our division, and then Nana Busampra, who was the research assistant on this project, presented these findings at our international conference. Again, without getting too much into the definitions, but of our 120 subjects, we had about 75% could meet a pretty liberal definition of sleep apnea. Mostly what I wanted to show you on this slide, though, is that we have people who were in their 50s. We had 15% women. So these are some of the first data of sleep apnea in women. Overweight, and then similar racial sort of breakdown, but we also had about a quarter of our sample was of Hispanic ethnicity. And I sort of pointed out these two definitions before. There's the Medicare or 4%. And again, in our cohort, about 50% of our patients met that criteria for sleep apnea, with 40% having moderate to severe sleep apnea. And then using the American Academy of Sleep Medicine, again, about half would meet moderate to severe criteria. So again, many people with sleep apnea coming out of the Owen Clinic. And unfortunately, we found that these questionnaires, whatever kind of threshold you want to use, none of these questionnaires was sensitive or specific. So these are, the kinds of curves where you're looking at specificity on the x-axis, sensitivity on the y-axis, and you want the area under the curve to be all the way up to the top left here, and you would get a value of close to 1. The dotted line would be essentially, a worthless test. And you can see that none of these screening tools is very good for detecting sleep apnea. You miss a lot of people, and you would also send a lot of people for tests that don't have sleep apnea. So what should we do? And I feel bad about this part of the talk because, I think I'm left saying I think you need to have a high-end index of suspicion for sleep apnea in your patients. And in a perfect world, you would just send them to us in the sleep clinic. And I think, unfortunately, referrals to the UCSD sleep clinic are still problematic. There's very, very long wait times for all patients. I think in the past, I could sort of help speed things up a little bit, but I'm now over with the VA. So, one small consolation is that if your patient happens to be a veteran, please send them to me. You can still send them to me, a message to me on the UCSD side, and I will try to help, but it's a real issue. What I did want to mention, though, are two things. One is that I've showed you a picture of someone sort of wearing the full Monty of sleep studies, and increasingly people are using alternative testing like this WatchPat device here, which essentially is a activity monitor on the wrist and a blood pressure cuff that goes up on the finger. And then there's one sensor that measures respiration here. But this device is disposable. You give it to patients, they wear it at home. They need a smartphone, though. I bring this up because towards the end, I'll mention this, but we spoke with Heidi Crane at University of Washington, and they are doing sleep studies with this device out of their clinic. And I think there's a potential for some collaboration there. The other thing, I don't know if any of you have an Apple Watch, but increasingly there's other ways that people will learn that they have sleep apnea. So Apple has a FDA clearance for measuring, I forget the exact wording, but it's have elevated breathing disturbances. And if you wear an Apple Watch and you turn this feature on and it says you have possible sleep apnea, you definitely have sleep apnea. Okay, so it's really interesting that as a company, Apple has said, we don't want false positives. We will only alert when people definitely have sleep apnea, which is nice, and you can trust it if it says that that's what they have. But from a public health point of view, there's many people that have sleep apnea, and Apple doesn't care about them. They want to sort of protect that they look really smart. They don't want you going saying, my watch says I might have sleep apnea, and then when you do a test, you don't. But people are, there's more and more devices like this out there. Okay, so let me say that sleep apnea is very common, but who cares? Does it matter? And so this was really our aim one. We wanted to see if sleep apnea could explain fatigue in people living with HIV. And again, this was work that Jeremy Orr did, and Jasmine Velasquez was the night tech for most of these studies, and she presented these data at our international conference. We measured fatigue and sleepiness using questionnaires. We had their sleep apnea status from the overnight sleep study, and then we also got many other measures of sleep and activity using actigraphy. I'll go into actigraphy in a second. I'll jump to the main message first, which was, I guess, surprisingly, at least at first pass, fatigue is not related to sleep apnea status. So if you look at OSA severity on the x-axis here, and we measured fatigue using this FACIT-F score, and a lower score means more fatigued, we would want to see kind of a trend of worsening fatigue across sleep apnea severity. And that's not what we saw. So that was sort of disappointing. And I think part of the reason is that fatigue is actually like a really tricky thing. So we looked at how fatigue matched up with sleepiness, or using this Epworth sleepiness scale in our cohort. And you do see that the two things are related. So as people report feeling more sleepy, they also report more fatigue. But you can also see, this is all over the shop here. And sometimes people use fatigue and sleepiness and tiredness and brain fog and concentration and, restful sleep the same. But a lot of times it means different things to different people. So, using fatigue from a questionnaire is difficult, but it's what we have, right? So in this study, we did use something called actigraphy. This is a wristwatch device that you wear, and you can shower with it. You can wear it for a week. You can wear it for 2 weeks. And we really benefited from the expertise of Soli Ankoli Israel, who was a co-investigator on this grant. And these watch devices tell you things about light levels and activity counts during the day. And so you can kind of pair that up and say, here there's not a lot of light activity. Excuse me, there's not a lot of light levels here, not a lot of activity, they're probably asleep. And you can also start to impose or sort of infer a circadian rhythm here of when people are active or not. So you get a lot of data. We had people do this for a week. So in terms of fatigue and sleepiness and thinking about these sleep predictors, again, I told you that sleep apnea did not predict fatigue. It did predict sleepiness. And so I'm just showing you this figure here. This is our sleepiness score in our multivariate analysis, and only sleep apnea was associated with sleepiness, not age, not how much sleep somebody got, things like that. When you look at the sleep factors that associated with fatigue, it wasn't sleep apnea, it wasn't short sleep duration. It was interestingly lack of consistency of sleep timing and less circadian amplitude. So people that have not very regular sleep timing, not a very regular day, reported more fatigue. And this is a little bit tautologic, but if you're more fatigued, you had less activity. I think that's pretty true. But what's interesting is that you could consider some circadian interventions to try to improve fatigue, which has been done in other studies like bright light therapy, structured exercise, that kind of stuff. I think what's probably interesting for many of you on this call, the non-sleep factors that predicted fatigue, being on a non-INSTI drug regimen, which about a third of the subjects were on, had a very powerful effect on fatigue. So INSTI, much less fatigue, non-INSTI, more fatigue, depression and opioid use. So this was definitely not kind of the home run. I think we were really hoping that sleep apnea would predict fatigue, which we didn't see. Doesn't mean it's not a target for intervention. And I think we learned something about the possibility of circadian interventions in these groups. So that's sort of fatigue and sleepiness. What about cardiovascular comorbidity? So this is also out of the MAX cohort by Dr. Punjabi, just published last year. And in the non-HIV members of MAX, you can see sort of a dose response curve between severity of sleep apnea on the x-axis and likelihood of hypertension. So it sort of squiggles around, but the more likely you are, the more sleep apnea you have, the more likely you are to have hypertension. And this is adjusted for everything that you can think of. But what was really fascinating is that in the HIV part of MAX, there really wasn't that dose response curve. So people were just as likely pretty much to have hypertension regardless of OSA status. And I don't know much about this. Many of you on the call may, but I guess there are some suggestions that HIV itself or antiretroviral therapy can contribute to elevated blood pressure or hypertension. In our cohort, so there was not a clear relationship between sleep apnea and blood pressure in people living with HIV. So I don't think that you should necessarily be prescribing CPAP to get somebody's blood pressure down. I think you should give them an antihypertensive, and that's true in people without HIV as well. But it was interesting that this relationship is altered by the presence of HIV. Now, in our study, I briefly mentioned that we use something called peripheral arterial tonometry. What that is you blow up a blood pressure cuff on somebody's arm, and then you measure the blood flow downstream on the finger. And so if you look down here, you have a certain amount of sort of pulsatile blood pressure in the finger, you occlude that for 2 or 3 minutes. And when you let the cuff down, if you have a really healthy cardiovascular system, your endothelium makes nitric oxide and you vasodilate and you get a really robust increase in blood flow for a period of time. So, this bump up higher is better. And in our cohort, we measured this in the panel on the left here. And I mean, if you really squint, maybe you would say that as sleep apnea gets more severe, there's kind of a tendency towards a lower cardiovascular health. This is a pretty bad relationship. I would just say this is where some of our science comes in, where we sort of found that the subtype of sleep apnea was more predictive of the cardiovascular effects. And this was a priori hypothesis we had that this loop gain or control of breathing um, sort of metric that we used, that has been associated with your sympathetic response. And so when we actually model it as sort of a low, medium, and high control of breathing, then these numbers start to make sense a little bit. So, the idea that sleep apnea that all kinds of sleep apnea leads to cardiovascular problems, we're trying to sort of break that down. And that's something we learned that I think we can take to non-HIV populations as well. And then, the other thing to think about, does sleep apnea matter in people living with HIV is sleep apnea lead to more inflammation in some way? And this is work that's under review now that was done by Alexia Perryman, Laura Crotty-Alexander, and with statistical support on all of these with Sonia Jain. In the three biomarkers we looked at a priori were interferon gamma, TNF alpha, and IL-6. And just to eyeball this, I guess you could look at the p-values, but there weren't real differences between OSA and non-OSA in the blood samples we took the morning after somebody slept in our lab. But again, what's interesting is if you sort of look a little bit more deeply at this, not all sleep apnea is the same. And so, when you look at this metric where you add up all the hypoxemia, it's really the hypoxemia related to sleep apnea that was associated with interferon, for example. So again, it's this idea that there's different kinds of sleep apnea, and what kind you have might determine what kind of sequela you have. So to wrap up kind of this section here, I think that OSA is important for tiredness. I couldn't say that it was clearly related to fatigue. But we found some interesting associations with possible circadian interventions that you could do. And it doesn't rule out the possibility there might be an effect when you treat sleep apnea that you would improve fatigue or other things. So I'll just move on to the last part of the talk here. Does treatment of sleep apnea help people living with HIV? So this is work led by David Berry, who he graduated from UC Santa Barbara and was looking for a project. And I said, I have a ton of data. And David just started this year as a first-year medical student at the Idaho College of Osteopathic Medicine. And we treated our patients with CPAP. And so I show this picture because I think many people have the idea of kind of the Darth Vader mask, but this is more typical of kind of the nasal pillows mask we use for CPAP these days. And this was just published a couple months ago. So in our study, we had about 120 subjects who came in. We had to rely on a 4% oxygen desaturation to sort of say sleep apnea or not, because 4% was what would be covered clinically. And at the start of this study, if somebody had sleep apnea, we referred them to the clinic. We got them on clinical care. Once COVID happened, that like totally broke down. We couldn't get people in the clinic. We couldn't get them CPAP, supply chain issues. So we then started providing CPAP therapy on our own. So this number from 70 people who met criteria to be treated with data in 41, I will just say that was the best we could do kind of in the pandemic. So, how we sort of lost people, it was less about people being willing to use CPAP or sticking with it. And it was more about we just could not actually get CPAP therapy to them in a timely fashion. So this is based on 41 subjects who had 3 months of PAP therapy. So first thing I want to show you is that both fatigue and sleepiness improve with PAP therapy. So what you're looking at on these slides, and I'll show a couple like this, is that you have on the x-axis is the score before CPAP, on the y-axis is the score after CPAP, And if the dots lined up on the line of identity, there would be no change at all. But for the facet score, you can see that things kind of group, to the left of the line here. And we put a little positive to help orient you. But these scores being more positive after CPAP therapy means that there was an improvement in fatigue. And the median improvement in fatigue score and the facet score was 3 points, which is above the minimally, what's thought to be the minimally clinically significant difference. People reported generally less sleepiness, which is improved sleepiness after 3 months of CPAP therapy. And it's a little hard to show on the grayscale, but the improvement was not clearly related to the baseline OSA severity. And again, we know that from non-HIV populations as well. I have people who have what I call mild sleep apnea who can't get out of bed in the morning. And I have people who I think shouldn't be able to wake up in the morning and they feel, pretty asymptomatic. So, just because someone has an AHI of 9, if they're telling you they have symptoms, you should treat them. It's not, oh, you just have mild sleep apnea. In terms of cardiovascular data, that reactive hyperemia index, that cardiovascular measure, also got better, and fewer people met a cutoff value of sort of concerning cardiovascular health after 3 months. And just one thing that was interesting is the heart rate. We're just doing single measurements before people started CPAP and afterwards. Blood pressure really didn't have much difference, but the heart rate was 5 beats lower after CPAP treatment, which we thought was interesting. So kind of to wrap up, in terms of treatment of sleep apnea, I would say it's one of the few things you can do to improve fatigue. We don't really have well, I guess we do have anti-fatigue medicines if you're excited about prescribing stimulants, but this is one of the things that you can fix to improve fatigue. It seems to have modest effects on cardiovascular health. And so in general, I think like people without HIV, if you treat sleep apnea, you can make them feel better. I'll just finish up with a couple slides here, but I think this is actually an exciting time for OSA therapy. And so I know that many patients avoid the sleep clinic because of, I don't want to do CPAP. Probably like you, the GLP-1s are very hot in our field. And so, this was a study that Atul Malhotra, one of our co-investigators, led and was in the New England Journal of Medicine last year on tirzepatide for the treatment of OSA and obesity. And if you take tirzepatide for a year and you lose about 20% of your body weight, your apnea hypopnea index comes down by about 25 to 30 events per hour. So really big effect. And this study led to tirzepatide being the first medication to be approved for the treatment of sleep apnea. So suddenly sleep medicine clinics are really, really popular because even though people don't want CPAP, they do want insurance to pay for their GLP-1. And so we're sort of managing how to help with that. The other thing below the blue line is that, for many years, there's been an implant, a stimulator, a pacemaker for the tongue, and there are other devices coming out for that. So this is a newer device, which was just approved a couple months ago. There's something that is implanted under the skin, which you can't feel. And then at night, you put a battery like that sort of connects with a magnet, and that's the power source. And that does pretty much the same thing, but now you don't have to have something that gets you flagged at an airport. And then as I was sort of thinking about, boy, we've published all this stuff, all this new data is coming out. I saw a presentation by Heidi Crane at the University of Washington, and she had just gotten a grant to, many of you know what CNIX is, but she wanted to try to add sleep and sleep metrics to CNIX and then use some of these tools to look at OSA prevalence and screening, all of the same things that we've done. But two things. I think one is they're doing an ongoing study at 2 sites where they're giving subjects WatchPat and putting that data into CNIX. And it sounds like there's room to collaborate, and it could be something where we could be a site for that. I also think there is so much more if CNIX was a little bit more robust. And I had looked a few years ago and there wasn't quite enough there. But, in terms of sleep apnea, insomnia, sleeping pills, I think there is so much to look at. And I think the whole field of sleep apnea, HIV, important comorbidities is a really rich area. So I'll kind of finish up and just say I hope I've given you a little bit of a primer on what's obstructive sleep apnea. I think we now have better data that sleep apnea is important in people living with HIV. It's very common. Unfortunately, we don't have great screening tools, so I think you just have to remember that many of your patients are going to have sleep apnea. I went over a little bit about how sleep apnea might affect symptoms, comorbidities, and inflammation, although clearly more to be done. And I think importantly, if you treat someone with sleep apnea, they will feel better, and they do have some modest cardiovascular benefits. And I think I will just acknowledge, I think I have everybody else pictured except for Igor, Miley, and then Pam DeYoung is our research coordinator in the sleep lab. So I will stop there and see what questions people have. Thank you so much.
Thanks so much, Bob. That was a great talk. We do think of you. You're our fifth Beatle, I think. Susan has a
Thank
bunch
you.
of questions. Susan, do you want to just
Sure.
you're
I
the
was
first.
writing down questions as
I
I went.
love
It was a
it.
great talk. So, first, why do women catch up postmenopausally? Is it
Um,
hormones? Hormones? Is it what is it?
we think hormones. So, just by analogy, because my other hat's in the ICU, so we see patients with liver failure and they don't clear progesterone, and they have a respiratory alkalosis. And similarly, in pregnancy, progesterone will stimulate respiratory drive. And so I think the some of the hormones stimulate respiratory drive, but also stimulate respiratory muscle function of the upper airway.
Oh,
I
okay.
will also say there's some fascinating work being done now about sleep apnea and pregnancy and maternal and fetal outcomes with that. So, stay tuned on that. But same kind of idea that there are a lot of that hormones affect sleep apnea risk.
Okay. And maybe I'll collapse two of my questions, which is the management of sleep apnea, OSA, among everybody CPAP? So tirzepatide lose weight and CPAP is are there any other modalities or is CPAP it? Not that it's
Um,
bad, but
yeah, no, I mean, ResMed gave a big donation to our sleep center, so I can't say CPAP is bad. No, I mean, I think
yeah.
CPAP is not CPAP is still first line therapy for many people, but I think increasingly there's been a few big shifts. I think one shift has been that in mild sleep apnea, you can be very symptomatic, but you're not going to have a heart attack or stroke. Okay. And so I think that we don't push CPAP for lack of like when I was in training, I heard doctors say if you don't wear your CPAP, you're going to die. And this was for people that had, an AHI of like 10 or something minimal. And so if you have someone who has obesity and they have mild sleep apnea and they're not very symptomatic or, like their partner sent them in or whatever, you have time now to work on weight loss and tirzepatide is a great way to do that. I think probably like many of the clinicians on the call, like, I mean, I've had people come in where I'm like, oh my God, like you have lost so much weight and their sleep apnea goes away. By the way, I say, how did you do that? And they say diet and exercise, doc, or willpower. And then I'm like looking through their medication list, right? And you see the
Yeah.
GLP-1. But so weight loss, because we actually have an effective, not super invasive way to lose weight, I think weight loss is becoming first line therapy for less symptomatic people who are overweight or obese. Really obese because that's how we get insurance to pay for it. And
Yep.
then I think we don't always treat people if they're not symptomatic as much. And then yes, still the vast majority is CPAP. There are mouthpieces, there are those implantable devices, but most of the time you have to fail CPAP first.
Yeah.
So let me just, and then I'll say one other thing, and I'm sorry for taking so long on this. Now that I'm at the VA, I see a ton of patients who have PTSD, insomnia, and our vision is that yes, some of those people, it's more of a sleep problem and not an upper airway collapse problem. And now we're going to give them CPAP, which is something on their face, they have claustrophobia, whatever. Um, and we know that their adherence based on those people with a sleep problem is really low. Like people have done studies. So we would think about using potentially drugs like sleep drugs to treat their sleep apnea. And we've done that as proof of principle. The problem is, what drugs are kind of safe. There are some orexin receptor agonists that are new sort of insomnia medications, and we're really interested in that. So anyway, still
Okay.
CPAP is the short version, lots of other stuff. And
Yeah.
somebody mentioned, oh, Tim, yes, didgeridoo therapy. So there was this idea that you might be able to train the upper airway muscles, and this fascinating study where a guy who played the didgeridoo, like in Switzerland, but somehow knew, and that's that Aboriginal instrument, they're wow, wow,
Yeah. Yeah.
um, hasn't been fully replicated. I'll just say that. And
And
oh,
maybe I could
last
just,
question.
oh,
Yeah, your question about tirzepatide affecting the AHI entirely BMI related. So a tool published that in New England Journal. I hope I'm remembering correctly, actually, because I think it's coming out like in the next week or two. They have a subsequent mediation analysis in Nature Medicine that's been accepted, and pretty much it's all the weight effect. I mean, they looked at these
okay.
other things, but I'm like 95% positive, but I'm not a co-author,
Yeah.
and I know of it and I haven't read it in great detail.
Okay. And
Um,
maybe just one last question. Is there a need to monitor people with severe sleep apnea who have who are on CPAP? Do we need to monitor their response to know that if they're not overweight?
Yeah, so what's really great about CPAPs, and one reason why they are still a preferred therapy is that the CPAPs do two things. They phone home every morning, and so it used to be people would have to bring their CPAP in or an SD card,
Oh,
but now it goes up to the cloud. And so I don't do this, like I don't log in every morning and see how people are doing, but you could do that. And so that's one thing is you monitor adherence. The second thing is that the devices also report what's the residual apnea hypopnea index. And so you can assess the effectiveness and the adherence to therapy in a pretty sophisticated way now. Yes, absolutely. Like I have set up a patient with CPAP on Friday because at the VA, when the VA wants to do something well, it does it really well. So, if I have a patient in front of me with severe sleep apnea, I can give them a CPAP, and Monday morning I can look in and see, yep, Friday, Saturday, Sunday, they use it and it's working great for them. Or they have a high leak, I need to switch out their mask or whatever. You get a lot of data from these devices now.
all right, last question, just looking at the time. So Gigi asked about the link between insomnia and obstructive sleep apnea. I think you talked
Yeah.
about that in 2020. And then Tyler asks a question about circadian rhythm disruption related to insomnia and the use of melatonin, which may or may not be related to OSA. So I guess two separate questions.
Yeah. Everybody loves like acronyms. So COMISA or co-occurrence of insomnia and sleep apnea is very hot in our field. And I would just say the best practice now, if you can swing it, is that you treat the OSA and you try to move ahead with cognitive behavioral therapy if it's available, but treating both at the same time, not sequentially, which is often what people had sort of done. Like, we have to treat the sleep apnea before we treat the insomnia. That doesn't work that well. So treating COMISA at the same time. And I mean, melatonin in general, most people take it as a soporific, like, I want to take 20 milligrams or some really high dose of melatonin to like knock me out. The studies that show that melatonin really improves sleep are where you help align the circadian rhythm and you take a zero point 0.5 milligram or something, 2 hours before bedtime. Um, I think, yes. I mean, I think there is a role, but it would be really interesting to study melatonin and insomnia and sleep apnea. But sleep fragmentation and sleep apnea probably alters melatonin production. And I'm sure there are things about either HIV or medications that might alter endogenous production. So yeah, I think there's a role, but like I'd have to look more into it.
Well, that I think is everything, and it's 9 o'clock, so it's perfect. We appreciate you coming so much. And wow, lots of hearts and claps. There's so much
I know.
happening here.
Blowing up.
But I think we'll have to have you back sooner than 5 years. I swear I thought it was more recent than that. Similarly, it's all a blur post-COVID. So, but thanks so much, Bob, for joining us on a Friday morning. And everyone, happy holidays. I think we're off next week. Marvin, right? Confirm for me No talk next Friday?
It's
Yeah.
Thanksgiving.
Thanksgiving. I knew Thursday was, but I guess. So everyone enjoy your time
Great.
with family if you get it. And
Thank you so much. I really
appreciate
appreciate
it.
it, Jill. Thank you.
Okay, bye.
Bye.